active in research. She published more than 130 papers in reputed journals and has been serving as an editorial board member for several journals. Dr. Al-Katan chose an attracting title for a wide topic, and she will talk about giant cells in ocular pathology. I'm so excited to hear from her, and I would welcome her to the podium.
Thank you, Dr. Azza. It's so nice to be back here, at least for the Grand Round. I want this to be as useful as possible and interesting. I have chosen something that has mixture of several entities. So the objectives for this talk is to explore some varieties of giant cells. The reason why I have chosen this is that we came across two cases where we have seen giant cells in tissue. So I was starting to wonder and ask the residents, what types of giant cells do you know? And I'm going to also discuss a couple of cases that I have seen or come across with other attendings during my ophthalmic pathology meetings that I usually attend. So the easiest to start with will be the giant cells in infections, specifically the corneal infections. So if I put this picture for you, I want contribution from residents, and we have to be fast and quick because I want to cover most of the cases that I have put. So if this is a corneal infection, what kind of infection do you think it is? Yes, higher, عشان أقدر أسمع, please. Herpetic. So this is actually a viral keratitis. You have three conditions or infections in the cornea where you can see giant cells. One of them is the viral keratitis or the herpetic. Where is it going to be located? Where are the giant cells are going to be located? Do you know? Any of the residents? Yes, behind this membrane. And this is what you are going to actually see. And you have to know that this might explain the keratouveitis that you get with herpetic infections, and that the virus itself can be isolated and can be seen in the tissue, in the corneal tissue. It's not only an immune reaction as was thought before. So this is just a picture of the giant cells that you can see behind this membrane. What's the second infection where you can see giant cells, corneal infection? If I show you this, fungal, exactly. So this is fungal keratitis. You can see granulomatous inflammation with or without giant cells in about 14% of the cases, and these are the giant cells that you can see. Of course, you need to do special stains to visualize the fungi in a better way. I want from residents, again, GMS, and as well the PAS. The PAS stain will also show you the fungal elements, as you can see here. You can see them here, but of course the best will be the GMS, as you said. The third infection where you can see giant cells in the cornea, maybe this will give you a hint. Yes, acanthamoeba, exactly. So you can also see it. You can see the cysts here within the tissue. We don't usually see much inflammation, and there is usually loss of keratocytes as well, but you can see giant cells as well, okay? Other infections will be mostly the mycobacterial, whether it's corneal or intraocular, and whether it's mycobacterial atypical one, or whether it's Mycobacterium leprae, or even intraocular tuberculosis. And the giant cell in tuberculosis, what is it called? Langerhans, not Langerhans, Langerhans, okay? And this is just an example of choroidal granuloma in a case of intraocular tuberculosis with the Langerhans giant cell. And what organism do you expect? Yeah, okay. So what special stain would you do to show the organism then? The acid-fast stain. And this is what you are going to see if you are lucky enough. So we came across all the possibilities in terms of infections where you can see giant cells. Now we'll come to another entity. It was a case that was presented in one of the ophthalmic pathology meetings. A 6-year-old male, he had injury to the right eye, a weird kind of injury actually. His brother threw a caterpillar into the eye. And this is the appearance of the eye, severely injected, of course, in addition to some caterpillar hairs that we're seeing. I don't know if you can visualize them here, maybe with the higher power. Luckily enough, the cornea was not affected. There was no perforation or anything like this. And they tried to excise or remove these protruding hairs, but they had several hairs embedded in the conjunctiva, and it was almost impossible to remove them. So they did conjunctival biopsy. Also, they have found, of course, granulomatous reaction with foreign body multinucleated giant cells. So that's another setting where you can see giant cells. They actually brought a caterpillar to the lab. They wanted to see what is the configuration of this hair, and this is the configuration of the hair shafts of this caterpillar with protrusions or barbs angulated at 30 degrees, and that's why they will introduce a strong granulomatous reaction with giant cells. And when they did deeper sections, they were able to visualize these hairs within the tissue. So you have to keep an eye on such infections, or not kind of infections, it's like a foreign body or injury, because it might cause keratoconjunctivitis, it might cause papillitis, it can even penetrate the globe and cause endophthalmitis. So this is one of the injuries that can be classified. They have classified this into 5 categories, with the least severe one here on the top. So the case that was presented actually has fallen into type 3 with the granulomatous reaction and conjunctival nodules that was removed. Okay, other foreign body type giant cells, residents again. What is this here? And you have here the giant cell. It's keratin material. Okay, it happens when there is an epidermal cyst that ruptured. Sometimes it happens also with the dermoid cyst, but in this case, it's not going to be all over the place. It will only replace the wall. So this is a keratin granuloma. What is this structure here at the arrow? In relation to possibility of again, epidermal versus hair follicle cyst rupture or something. It's a hair shaft, okay? What is this structure here? You can see also granulomatous reaction with multiple foreign body type giant cells. These are suture material, actually. So this is actually a suture granuloma that sometimes we get to see. It depends on the type of the suture, whether it will polarize or not polarize, and the thickness of the suture material itself, and so on. So it depends on what type of. The other setting you all know where we can see giant cells is in temporal arthritis. Where are you going to see it? Okay, around what exactly? Internal elastic lamina, exactly. So there is fragmentation of the internal elastic lamina. This is a more or less normal artery, just to show you the layers of the artery. What are the layers here inside? Intima, yes. And this is the internal elastic lamina, and then the media, and then the adventitia. So this is a normal human kind of speak. What is this stain? Okay, so you can just simply say elastic stain. It's the best to highlight the internal elastic lamina. So when there is fragmentation here, the granulomatous reaction is going to be centered around the fragments, and then you will have giant cells. They are kind of also foreign body type giant cells. So as you can see here. And if we go by higher power, you can see the internal elastic lamina here, but this is with an H&E stain, and you can see the giant cells where the arrows are. Some more giant cells also in another case. But I put in the title, how about if giant cell arthritis is not giant cell arthritis? We face sometimes a problem when the case is already burnt out, and when you look at the temporal artery itself, you do not really see the features characteristic of giant cell temporal arthritis. So what do? You have to be very careful in seeing the adventitia as well, and the tissue around it. So if you concentrate on this area with higher power, you will tend to see the interruption of the internal elastic lamina of the small artery that's feeding the temporal artery with similar granulomatous reaction here. So you can still diagnose it even in burned out cases. We'll move to completely different type of giant cells presenting this case, which was in a 6-year-old girl with an upper lid swelling, a little bit of a redness or a purplish hue. Nothing else except in the history except an excised hemangioma in the right cheek. But we thought maybe it could be related, maybe another vascular lesion. But anyhow, this is her clinical appearance. Would you put rhabdo in the differential? Yes, more or less? Well, not convincing. Not much, maybe. Okay, anyhow. They thought clinically that it might be rhabdomyosarcoma just because of the kind of discoloration here. And with the CT scan, there was a soft tissue lesion and destruction of the orbital wall, as you can see here. But there was some sort of cystic component. So the radiologist thought of maybe fibromatosis, maybe metastatic neuroblastoma because of the age. But when we did the tissue diagnosis of the biopsy that was taken, we found numerous histiocytes and giant cell formation, okay, in addition to eosinophilic granulocytes. And this is the appearance that we have seen with several giant cells. Any clue? They are not really two-tone looking that much. But if I show you this immunostain, Tariq should be able to answer this, which were Langerhans positive. So, which type of histiocytic lesion? Yeah, say it loud. Langerhans cell histiocytosis. So that was the diagnosis, which is proliferation of Langerhans cells. I just brought this because you have to differentiate. Whenever you see histiocytes, you have to differentiate between Langerhans cells or histiocytes and the non-Langerhans. And we usually do this by immunostains because the Langerhans cells are usually confirmed by CD1A and S100, while the non-Langerhans will be positive to CD68 or 163, and they are going to be actually negative to this. But Langerhans is even more peculiar and more specific, the one that we have used. So you have to include this in the differential diagnosis of such MS. Now, do you think that this is xanthelasma? Yes? Yeah? Who would say yes? I want hands up. Okay. Just few. Anyhow, this patient presented with these skin lesions, and we thought at one stage maybe xanthelasma, all right? But then careful examination of the eye itself showed these areas here. Can you link the two together? Actually, this was presented by one of our residents last Grand Round. The people who were attending, who attended the case presentation before with him. Any clue? What do you think this would be? Yes, yes, I heard something. Yes, this is subconjunctival silicone here. So do you think that these patches in the skin also might be silicone? Maybe. The plastic surgeon who did this, the oculoplastic one, thought that, no, this is not silicone. It really looks yellowish, and he thought it's xanthelasma. But it turned out that, as you mentioned, that she had retinal surgeries before, and with silicone removal and so on. And when we link all the pictures together, this is the histopathology down there in C and D, and you will see giant cells actually and macrophages or histiocytes around the empty spaces of the silicone oil. So it turned out to be a silicone oil granuloma, and you have to keep in mind that silicone oil can really migrate, not only in this area, but even to the orbit. Another case of xanthelasma, okay. Again, yellowish skin lesions, history of hyperlipidemia, so maybe suggestive also of xanthelasma, and a previous biopsy done elsewhere, and this is the patient. So do you think xanthelasma? Yes? Yes or no? Maybe? طبعا أكيد أنا حاطة الكيس لأنه it's not. فبس يعني let's say إنه maybe. That was the biopsy that was diagnosed as xanthelasma. What are you supposed to see in xanthelasma? Residents, especially R1s, foamy histiocytes, yeah. So the oculoplastic who did this case told me, no, I'm not convinced that it is xanthelasma, even though it was diagnosed outside as such, because there is deep orbital component. So they took deeper biopsy, and you can see here that there is actually orbital fat tissue. So there was lots of histiocytes, foamy histiocytes, but in addition to this, there was two-tone giant cells, as you can see here. So what would be the diagnosis? Xanthogranuloma, but in this case, it's an adult onset, of course. And this is a better picture of the two-tone giant cells. And this is even another better one that I borrowed from Dr. Charles Eberhard from the States. So orbital xanthogranuloma. I don't want to dig deep into each category because we have plenty of cases to present. Another patient, proptotic and breathless. That was also one of the cases presented in one of the ophthalmic pathology meetings. This is his appearance. He's a 74-year-old male. And he had this progressive chemosis and injection and tearing in this eye. His positive past history is positive for prostate cancer. So they also kept this in mind as well when they dealt with him. But the main complaint was mainly proptosis and limited motility, the chemosis, as I said, and the corneal exposure. So they did also the imaging as expected, and the CT of the orbit showed the both left and right orbital involvement. So any clues at this stage? So it's not only in the bad eye that he presented with. He has manifestation in both. Plus meningeal beads, solid enhancing masses at the high frontal lobes as well. So we are talking about what? Something systemic. We are not talking about. Differential diagnosis will include lots of things, maybe malignancy, inflammatory, infectious as well. So what's the next step? Like always, you always need us. You have to do biopsy and consult the pathologists. They did the biopsy. This is appearance afterwards, okay? But at that time, even before the results of the biopsy, he was admitted for shortness of breath. And there was no improvement in his hypoxia. So he was really in a bad shape, for which they did CT scan of the chest, and it showed lots of findings, actually. Interlobular septal thickening, diffuse ground glass opacity, pleural thickening. So they thought of interstitial lung disease. Can you connect all the stuff now? How about if I show you this tissue? Again, mixed inflammatory cells, but some two-tone giant cells. Maybe not as nice as the ones that we have seen before, but they are positive, lots of positive cells to CD68. Again, Tariq, your thesis. CD163 positive as well, and factor 12 positive, but S100 negative. Okay? So we excluded the Langerhans type, as you said, and it is indeed Erdheim-Chester disease. So again, it's not one of the pleasant things to have. But it can present as xanthelasma to start with, in addition to proptosis and orbital masses. We have seen the xanthogranuloma, the adult onset ones, even in the cornea. That was the case of Dr. Ali Rajhi when I was here before. He was a 43-year-old male. He had bilateral corneal lesions, but one of them unfortunately was removed or excised elsewhere, so we didn't have access to the tissue at that time. But he had poor vision in the eye that was not operated, which is this eye, okay, on this side. The other one had reasonable graft. So we again removed the corneal lesion completely, and we also saw foamy histiocytes in addition to multinucleated two-tone giant cells, as you can see here. And our diagnosis was also corneal xanthogranuloma in an adult. At that time, we published the case, and we tried to see all the cases that were published before. The unique thing about our case in particular is that it was associated with multiple endocrine neoplasia type 1. We don't really know what is the relation between the two. Now, another case, a 35-year-old male with bilateral subconjunctival masses of 1 month duration. Systemically pain, non-specific joint pain, but he has also conjunctival redness, tearing, and headache. Okay. The major thing in the examination, diffuse conjunctival injection, more in the superior part with subconjunctival swelling. And this is his appearance. So very bad injection. Dilated fundus exam was fine. We did the CT scan of the orbits, and there was bilateral lacrimal gland enlargement. Okay. So they had a long list of differential diagnoses between the conjunctival nodules that were seen and the injection, in addition to the lacrimal gland enlargement. And they did also chest CT scan, which showed right lower lobe segment density, suggestive of atelectasis, but no evidence of tuberculosis or sarcoidosis. So the easiest was to do the biopsy from the lacrimal gland and biopsy from the subconjunctival tissue as well. For the lacrimal gland one, there was only mild non-specific dacryoadenitis. But for the subconjunctival mass, this was the picture that we have seen. So you can see also giant cells as well, okay? In addition to, if this is a blood vessel, there is inflammation centered around the blood vessel. Can you link all these findings together? Wagner's. So this patient was a case of Wagner's. Now another case of Wagner's, which of course is going to turn out not to be Wagner's. Okay, a 50-year-old female, okay, was seen because of redness in the eyes and diagnosed as bilateral necrotizing scleritis and treated accordingly with topical prednisolone and systemic oral prednisone as well. There was gradual deterioration, as we can see here from the date of presentation further on. Later on, had hypotony and light perception. Unfortunately, this case, I do not have any clinical photos. I just have the long history and the progression. Unfortunately, the patient ended up by enucleation of that eye, and she was referred to the University Hospital for treatment with cyclophosphamide. The investigations are here. The only thing that was positive ANCA. Okay. Further on, developed infection and actually ended up with exenteration. So very bad outcome. At that time, the diagnosis was Wagner's all the way through, since the start, since the initial management. And what happened is that at the end, she ended up by enucleation exenteration, and we did review the histopathology slides, not because the patient that was long time ago, she's an old patient, but because we collected cases of Wagner's granulomatosis to study them here actually at the eye hospital. I don't know who was with me, with one of the previous fellows. But anyhow, when we reviewed the histopathology slides, I told them, you know what, this is not Wagner's, definitely, because there are areas of necrobiosis, areas of cholesterol clefts, okay, and granulomas, with some giant cells. So I told them this is not Wagner's granulomatosis. And there was no evidence whatsoever of vasculitis. We did check all the vessels in all the specimens. So it's basically orbital granulomatous inflammation with giant cells as well, but with necrobiosis. So again, what's the entity? So it was a necrobiotic xanthogranuloma. So you have to keep an eye on these cases, the adult onset xanthogranuloma and their classification. You have to go back and read about them all, okay? Another granulomatous pathology in a child, another case that I borrowed from one of the speakers in the ophthalmic pathology, but this is a very interesting case. A 6-year-old child, at 12 months, he had low-grade fever, nasal congestion, red eyes, multiple small white yellowish nodules. So we are talking about something as well that might be kind of systemic. He kept having these problems, including joint problems, so joint fever, conjunctival nodules, so multiple complaints. And this is a picture of the subconjunctival nodules that he had. Not much, you know, like it's not really very prominent. But when they did the biopsy for these, it turned out to be granulomatous, again, granulomatous reaction. They did exome sequencing, and the patient showed mutation in the nucleotide binding and oligomerization domain of the NOD2 gene. And this was the basic thing that they put their diagnosis based on it, which was Blau syndrome. To be honest with you, when I attended that meeting, it was the first time for me to hear about the syndrome. I don't know if anybody of the audience has heard about it. No? So I thought it's, yes, you did? Yes, yeah, good, okay. So the patient progressed actually in a bad way. He had further corneal opacities, and then bilateral vitritis, as you mentioned, uveitis picture. And they tried to control the inflammatory disease, developed also corneal infiltrate, as I said, developed further on seizures, subarachnoid hemorrhage. Unfortunately, eventually had fixed dilated pupils, and he passed away, the child. Of course, you know, like in other countries, they do autopsy. So they did, you know, examine the eyes, and they found the granulomatous inflammation to be involving almost everywhere, whether it's the subconjunctiva, as we mentioned, the pars plana, the choroid, even the orbital fibroadipose tissue and the extraocular muscle. Everything was involved with these small granulomas. So here this is the granulomas in the bulbar conjunctiva with the higher power in the iris as well, in the pars plana anterior vitreous, and within the pars plana in particular, they managed to find these inclusions of the calcium and protein within the Langerhans giant cells. What do you call these? Do you know? The Schumann bodies, yeah. So they managed to see this in the pars plana as well as in the superior rectus muscle and in the orbital fibroadipose tissue. So just few words about Blau syndrome. You have to, again, read about it because it's a triad of granulomatous arthritis, dermatitis, and recurrent uveitis with early onset in childhood. The Blau syndrome and the early onset sarcoidosis, they both have the same mutation of the NOT2 gene, but the Blau syndrome is familial while the early onset sarcoidosis can be sporadic. And it has lots of ophthalmic manifestations up to, you know, like retinal vasculopathy, chorioretinitis, and variety of things. Now, giant cells can happen in the lacrimal gland as well. This case was a 59-year-old smoker, male. He had this superior-temporal orbital mass in the right eye, painless, so they didn't really think of something that's malignant. But they had this imaging also studies showing the mass, and they planned for, again, excisional biopsy of the mass, and this is the mass that they have seen. There was prominence of a spindle cell proliferation, as you can see here, with some specific vascular pattern. Maybe it's not the best here, but this is what they have seen. With higher magnification, the spindle cells tend to form some giant cells, which you can sometimes see in this kind of tumor. And there was strong positivity to CD34. Any clues? The basic science course? Yes, so it was solitary fibrous tumor of the lacrimal gland fossa. So you have also to keep it in mind. The solitary fibrous tumor, by the way, was previously known as hemangiopericytoma and previously known to have what we call staghorn blood vessels or vascular spaces. Another lacrimal gland lesion, okay, a 28-year-old male had progressive swelling also of the right upper lid, as you can see here in the clinical pictures. Again, non-tender, so we didn't think of something malignant. No associated inflammation or any redness, but there was some extraocular motility limitation and choroidal folds. The clinical impression at that time was extracorneal cavernous hemangioma, and they did the CT scan of the orbit, and the CTs in particular, they said no, most probably not hemangioma, it's a lacrimal gland tumor or lesion. So they did the biopsy, or the excisional biopsy actually of the case, and this was the mass. Histopathology, it came because it's a big mass. Dr. Maktabi, she knows. We cut this serially, and we end up by like maybe 8 slides or so to look at. When they brought the slides to me, I picked one slide, I put the slide, and I looked at it, and this is what I can see. Lacrimal gland tissue, so we are confirming that this is lacrimal gland. Maybe some sort of a capsule here, and some fibrous stroma. Yes, again, you can see the capsule here. And this is cytokeratin stain, just to stain the lacrimal gland acini. Okay, some dilated ducts, and some epithelial component here, which is glandular in appearance. What do you think I thought of? Pleomorphic adenoma, okay? This is higher power. So I looked at it, I thought, oh, pleomorphic adenoma, okay. Shall I look at the rest of the slides? Do I have to? Yes, That was the cytokeratin again for the glandular areas. So I looked at the rest of the slides, and that was the only slide that had this appearance in one focal area. The rest of the tumor was actually hypocellular versus hypercellular areas alternating, and some vascular proliferation, and mostly spindle cell proliferation, actually, which you can see here. Positive tumor cells to CD34, BCL2, and CD99. I didn't have the STAT6 at that time available. So again, the diagnosis, maybe, with this appearance, خلاص, you should know. It's again another solitary fibrous tumor with entrapped lacrimal gland tissue mimicking a pleomorphic adenoma. And this case had giant cells. I included it just because it had some giant cells in some areas. So you can see giant cells in solitary fibrous tumors. The last case is actually a case of Dr. Maktabi, 15-year-old male with lateral canthal mass. Again, when she brought me this case and I saw it, that was the first time for me to see such a case as well. So I owe her a new category. CT scan showed a well-defined hypodense homogeneous mass in the temporal aspect of the right lower eyelid. This is the appearance, and grossly it was a nodular mass that was removed with attached skin. I included the case because, in spite of the fact that it was composed of nests of epithelioid and spindle cells, in addition to some areas of myxomatous background, it had multinucleated giant cells as well, as you can see here in these photos. It might not be a very important entity for you for the sake of exams, but it's something new also to know and to add to your knowledge. It was positive to CD68 vimentin and to pudoplanin, which is a mesothelial marker, in addition to microphthalmia transcription factor, the MITF. Negative to other things that we were thinking of in terms of fibrous lesions, pigmented lesions, and so on. And we did also colloidal iron to highlight the myxomatous areas. These were the immunostains that we mentioned, okay? And the diagnosis is neurothekioma, okay? Dr. Azza is the one who made this diagnosis, not me. And it was published also. So just keep an eye, keep it in your mind as well, because it's traditionally referred as a benign superficial cutaneous neoplasm of peripheral nerve sheath origin, and it's classified into several histologic variants depending on the appearance and the myxoid differentiation. Other types of giant cells, this is for you. I'm not going to say anything because they are not just cases, they are just pictures. So can somebody tell me what we are seeing here? Residents, basic science course, R1. What's the tissue, at least? Skin. What do you think these are? With a clear zone between the epidermis and the collection of the cells here. It could be a nevus, yeah. And these are the giant cells. So these are intradermal, it's an intradermal nevus with nevus giant cells. So that's, Demodex as well. Okay. Another case, it's difficult for you to figure it out, just based on the picture, so I put the diagnosis here. We just had it recently, a patient presenting with orbital mass, and it turned out to be a plasmacytoma, collection of plasma cells. Some of them are immature, and also, again, it carried some plasmacytoma giant cells. I'm not going to go through the case because it will be presented by Dr. Suleiman Toregi, one of our residents, this afternoon. So I just thought I will put only the histopathology pictures because it carried giant cells. So I hope that that was useful and interesting as much as possible, because I know that pathology is a bit boring. We came through giant cells in infections. Okay, foreign body type giant cells, giant cell temporal arthritis, Langerhans cells histiocytosis, and Langerhans giant cells in TB or Schumann bodies in other conditions, as we said. Xanthogranulomatous disease and giant cells, you have to keep all in your mind. Solitary fibrous tumor that can affect the lacrimal gland or any other tissue in the orbit, as you can see, and can have giant cells. And finally, the neurothekioma of the case of Dr. Azza Maktabi, and the nevus giant cells and the plasmacytoma giant cells. Thank you very much.
most of the audience enjoy it. So I will open
Sure.
the floor for questions.
No questions? Okay. All right, that's good. It's good that they don't have questions. All right, but please go and read about these entities, the residents. Try to link what we have seen today with information, clinical information about these entities, okay? طيب, we will have the quiz. Shall we have it immediately على طول now? The quiz? Yes? Okay. خلاص, we'll wait. Just let me know. قديش قعدنا يا عزة احنا؟ ساعة ولا أكتر؟ أقل. أنا شلت one case ثانية.
بس نايس يعني.
لأن شلت كيس كان سوريت الفايبرس تيومر بس متكلمين فيه عن ستات 6 والريليشن اوف ات تو ذا باثوجينيسيس. بس لا خلص خلي يعني.
حلو الكيس.
أنت عايزك تعملي تكملي؟
خواجه مش
نيورتك يوم؟ لا بس it's your case. كملي أنت لو تعملي لو تعملي هل كنت بدأتيها على الكالسيفيكيشن؟
لا انا حطيها
أو يا حلوة بس خسارتها السي تي ار، خليها الجراند راوند. يعني سي تي ار تقدر تحطي أي شيء أنت حالات عادية باثولوجي. من أعطيتهم أنا 1 سي تي ار عن الريتينوبلاستوما، أعطيتهم 1 سي تي ار على كورنيال ديستروفيز I think أو كورنيال ديزيزز. يعني سي تي ار يعني سهل تطلعي، بس حاجة زي كده topic like this if you do it in the same way وتشوفي ايش الكونديشنز والحالات اللي ممكن تعمل. حلوة. طيب updated حلوة الجراند راوند يعني خسارتها. خلي الناس شوية تعرف إن احنا بنشتغل لينا قيمة شوية، صح ولا لا؟ ممكن أطلع آكل شيء.